Does a dying person have the right to get a doctor to help end their life? It's a question that once again is up for debate at the Minnesota legislature. Supporters say this could be the year medically assisted dying becomes Minnesota law. Opponents say not so fast. The danger of abuse could cost unwilling patients their lives.
Now, this is Talking Points on CBS News Minnesota.
Good evening and welcome to Talking Points. It's a question every family confronts. The death of a loved one, sometimes tragically unexpected, and other times painfully dragged out by medical advances and unpredictable rebounds. This is about that second option and whether Minnesota should join other states, 10 other states, to allow the dying to get help from a doctor. Supporters say it's about choice. Critics say it's just the opposite, a decision easily manipulated to make the dying a victim. Tonight you'll hear from all sides about a bill before the Minnesota legislature that has the best chance of passing in the 10 years it has repeatedly been proposed. First, let's start with someone in the fight. Nancy Uden. Despite suffering from glioblastoma, a fatal brain cancer, she has attended news conferences and lobbied for the right to die. All right, joining us right now is Nancy Uden. She is a glioblastoma patient who has advocated for the choice of the right to die. Nancy, thank you so much for joining us.
Thanks for having me.
We were talking earlier, you were diagnosed with glioblastoma back in 2022. That must have been very devastating, but this happened, you were diagnosed after you were told you had something else.
Right.
That
Right.
must have been very difficult, but you feel it's really important that you have the choice to go to a different doctor, and which you did. You advocated for yourself.
I did. And you sort of have to advocate for yourself all along the way. And that's what sort of mortifies me sometimes around opposition to this bill is that I can't quite reconcile people not wanting choices. And whether you want the choice or you don't, that you are taking it away from me. And there's so many choices along this journey. I mean, the first was to get a second opinion. The second was, do you want surgery? It doesn't come without its risks, particularly at my age. I'm 72 years old. And there was at that time about a 9 to 10% chance that something would go wrong. Maybe I'd end up with a stroke. I would end up something getting touched in the brain that wouldn't allow it to work anymore, whether it was my legs, my eyes, my whatever, And so I went into it with a choice, but certainly not without risk. And
yeah, let me ask you this. Why, I think people will look at you and say, you're amazing to go and sit through this and tell your story, which has to be difficult, at hearings at the Capitol, to report, nosy reporters like me. Why are you choosing to be so public about this in your advocacy?
because of how hard it is for me right now in terms of, okay, I have a terminal illness. It's going to get to a point. I had a hospitalization just before Christmas that was a seizure, but it was an ugly seizure. And I was delusional. It was just not good. And I said, I have the feeling that this is what it's going to be like in the end. Sort of delusional, aggressive, my brain was just going to start to give out. And I said, my kids had to witness that. And that had always been sort of my motivation. I didn't want my kids to have to witness me having an ugly death. And so I have always been an advocate for this choice. And like I say, when I was diagnosed with it myself, I knew that I had two choices to make if I wanted this choice. One was to tell my family to take me somewhere else. And the other was to go out and advocate and make this a law in Minnesota.
All right. Well, we certainly, it is so impressive and so courageous. It's really remarkable. When you look ahead, is there a death scenario, and I know this sounds so grim, but is there a scenario that you would like or that you would like to emulate in terms of your leaving this earth?
Well, I can give you a couple of answers to that because it's just certainly not a point in time question. The first is that I have this, my mother died so peacefully. She had been in the hospital. We took her to a hospice facility because she was in assisted living. It just wasn't a good place for her to end her life. So we took her to a beautiful hospice facility. She died there so peacefully. I was there, my kids were there, my grandkids were there. We were all holding her hand and telling her how much we loved her. And when she died, she looked up, if you believe in heaven or don't believe, it doesn't matter, but she looked up into the skies and you just knew that she was there with somebody or something, or and I just watched her. It was just peaceful. And so I've said all along, that's how I want to die. That's exactly how I want to die. And then I had my brother died just about a year ago, and did the same thing. We took him to hospice. They said there's nothing else they could do for him. Same sort of thing. They took him off oxygen and he died peacefully.
What do you say to people who say this is wrong?
I asked the question, why? How is it wrong? And who are you to make that decision? I mean, if there was one set of laws in this world, maybe it would be a good thing, I don't know, but could be a bad thing too.
Well, let me ask you, describe two situations that I think all of us, as we all age, would like to die in that way, to be surrounded by family and peacefully. In terms of your advocacy, what have you said to people who have questioned this in terms of lawmakers? I know that you just talked about the personal, but the lawmakers.
Right. First of all, I tell them I'm not even sure why we're talking about this in a bipartisan way. That's the first thing. This is the decision. This is a conversation I should be having with my doctor. Okay. I've had other medical issues along the way, and my doctor and I have been able to figure it out just fine. I remember when my daughter was born preemie, and they came in and said she was struggling, and they said we have two choices. One was to treat what they thought was a staph infection, and the other was to not treat it until they could get the cultures back. Well, it's not a very nice choice to have with a 5-pound preemie child. And so I had a choice, and we chose to have her treated with antibiotics that could have killed her had she not had the infection. But had she not had the infection, we had her treated, then we would have overdosed her. Yeah. So that was a choice that that our doctor and I sat down and had together and said, what do we want to do?
Let me ask you, you described two really beautiful scenes of passing away with your family very peacefully, your mother and your brother. Let me ask you, I think all of us have had experiences with hospice with loved ones, whether it's at home or in a hospice facility. And they usually, in my experience, have provided you, the caregivers, with medications that can be used to make things easier, less painful. Isn't that close to the same thing that we're talking about?
It's part of the continuum.
Okay.
In my mind, we're on a continuum here, and there is. I already work with palliative care.
Right.
Their job.
Yeah.
Yeah, their job is to keep me comfortable and to make sure that I have what I need to live as good a life as I can live while I'm still here. And we have decided we're going to do hospice at home. I actually have a woman that I'm going to meet with when I get back from surgery about having a death doula, somebody to sort of be able to continue to be my advocate and make sure I get what I want in this death process, just like you would if you were having a birth doula.
I didn't know that was a thing.
Yeah. But the timing of this, I just have to make sure we get this in there. The timing of this, in terms of me making a choice, was when my diagnosis was made. I no longer had the luxury of being able to sit and theorize about this law and how important it was to me and how I wanted to, die someday. The someday is now. About a week ago, we've been having really good reports. About a week ago, we went down to Mayo, and my oncologist said, I don't have good news for you this time. And I have grown another tumor. The good news is it didn't grow in the same spot as the other one did. It grew, one was here, and the new one is here. But I want it out, knowing there's risk with it. So my family and I decided that's what we're going to do. We're going to take the risk. We're going to go, do this. But
I'm sorry, do the surgery or not do the surgery?
we're going to do the surgery.
You're going to do the surgery, okay.
I am going to do it. And I was also able to get into a clinical trial using immunotherapy, which I'm really excited about. But the legislature, the legislature has been beating on this drum for this is the 10th year. I don't have 10 years left, even under the best case scenario. I don't have 10 years. I don't know how long. You asked me that question way back in the beginning. What have doctors told you? I mean, I've had doctors tell me everything from a year to, I have patients that have lived 26 years. It's not me specifically, but it's what their experience has been. And that's all they can go on, is their experience and the research that they have. There are people that have lived with this disease for 10 plus years. Not very many, but it could be me. But in the meantime, I can't wait for the legislature to go another year. I said, I'm sorry, and you can use this if you want or don't use it, but I said, I really want to pass this year. I would really feel like I had left a legacy if I could be, part of this group that has been pounding this drum for so long. But if they don't pass it, and I don't pass by this time next year, I feel really bad for the people who didn't get this bill moved along, because I am going to be so upset, so angry. I'm not asking for people to take this on as their own personal burden. I'm asking people to let their legislature know that they don't care if that's a choice I want to make. They may not take it themselves, but they also don't want to take it away from me.
Got it.
And that's all I want is that. We finally have it going in the House. It just needs to get moved on to the Senate, and we need to get them to take some action. And like I say, the House has shown a good example this year of what it should look like. And I would encourage our Senate to take on the same sort of momentum,
All right.
and go with it.
Well, Nancy, thank you so much for sharing your story. You look fabulous. You look energetic. And certainly we pray that the coming weeks and months are as good as they possibly can be for you. And you do have a legacy. It's now
Right.
for this advocacy. So thank you so much. Really appreciate it.
You're welcome. You're welcome.
Well, joining us right now, Mike Freiberg. He is the representative from Golden Valley, and you have proposed, sir, this bill, essentially a right to die bill, for a few sessions now. Why are you doing this?
Yeah, thank you for the question, Esme. Initially, it was just sort of as a favor to a state senator. I mean, I was certainly supportive of it at that point, but she needed a House author, and so I agreed to do it. And just kind of the more I've been involved in it, the more convinced I am that it's the right thing to do. I've heard just heartbreaking stories from so many Minnesotans who are either seeing a loved one go through what they view as unnecessary suffering at the end of their life, or they're going through it themselves. I've heard from people in fairly late stages of terminal disease as well, who just want to have another option for the end of their life. So I think I first introduced it in 2015, and the senator has since retired, but I'm still here trying to push it along, and we've made it further this year than we have in any year so far.
Well, I did speak to Nancy Uden, who I know you're familiar with, but have you been inspired to go forward? It sounds like you have, from people who've reached out to you. I mean, what have they been saying?
Yeah, Excuse me. Yeah, no, that's very much been a factor in kind of just the will to kind of keep carrying the bill because honestly it does involve a lot of difficult discussions and difficult committee hearings. But when you hear somebody's story like Nancy, I've just become convinced it's the right thing to do. And I've been contacted by so many people, from my district, from outside of my district, who thank me for supporting the bill. They say that they've seen their mom go through cancer or ALS and just, at the end of life, just wished they had an option, where they could kind of end things on their own terms. So that's what the bill does. It's in place in 10 states. There's a track record that show that it works as intended and that some of the adverse effects that the opponents of the bill have highlighted haven't come to pass and won't under this bill.
Well, let me ask you about this. How do you respond to critics who say this is essentially murder? You're taking away somebody's life.
Yeah, this is just a bill that protects people's autonomy at the end of life. It's similar to the other bills we've adopted in the reproductive freedom space this year. It's just a way to respect people's autonomy at the end of life. I mean, these are not people who want to die. They're not suicidal. These are people who are already dying from a terminal disease, and they just want to they want to be able to kind of define things on their own terms and have some last autonomy at the end of their life, frankly. Um, it's not for everybody. Nobody's required to use it. No provider's required to provide it to anybody, but it's for those who want to use it and who can find a provider who's willing to provide it. It just gives them another option. And the data from Oregon show that something like a third of the people who get prescribed a medication actually don't end up using it. I think they just, wanted to be able to have that option at the end of their life. So some people use it, some people don't, but it's a way to respect people's autonomy and help them kind of define for them what's an acceptable level of suffering, an acceptable way of going at the end of their life.
And what are the specifics of the bill? Because I know that's something you've worked very hard on.
Sure, it's modeled after the Oregon law. It says that if two providers determine that you have a terminal disease, which means that you have 6 months or less to live, according to their estimation, and they determine that you have mental capacity, that you can make an informed decision, then you can be prescribed a medication that you have to be able to self-administer. So there's no injections or infusions allowed, but you can self-administer a medication that you will take to end your own life. Those are sort of the basic requirements of the bill. They've been in place since the bill was first introduced in 2015, and they're in place in the 10 other states plus the District of Columbia that have this in place as well.
And you have to self-administer it. You can't get help self-administering it?
I mean, if you have ALS or something, somebody could maybe
Yeah.
place it on your tongue, but you have to be able to basically swallow it yourself.
All right, finally, I know you worked on this for a while. It's gotten further this year. Your thoughts on its passing? Do you think this is the year?
I'm certainly hopeful. It's a little unclear what the status is in the Senate, but we're moving it along in the House. It just passed its third committee hearing today. It's got one more before it can go to the Ways and Means Committee. So it's definitely moving along. I feel like we've really advanced the discussion this year. I'm hopeful we can get it passed into law. But nothing's ever a guarantee in a legislative process.
That's certainly true. Representative Freiberg, thank you so much for your time.
Thank you, Esme.
Joining us right now, Dr. Rebecca Thoman, and she is with Compassion and Choices, Care and Choice at the End of Life. And you have been advocating for so many years, at least 10 years that I can remember, along with very wonderful people who have since passed. Why do you advocate for this, and why do you join up with these really courageous people who are advocating this near the end of their life?
Yeah, as a physician in training, I saw so many people suffering at the end of life. And of course, I have my own personal reasons I would like to have this option. But what really keeps me inspired and moving forward on this is the people who I have come to know over the years, the tireless advocates who used the final weeks and months of their life. They're dying from cancer and other diseases, and they're advocating for this, knowing that it wouldn't pass in time for them to use it anyway. But they had so much strong will and compassion, that they were willing to take their time, share their story publicly, and bring this information to the lawmakers who are the ones who will decide whether or not we have this option at the end of life.
What would this bill do? Can you be specific on what it actually would
Sure.
create in terms of law?
Yeah, it's designed after the original Oregon Death with Dignity law. It's a very, very specific clinical practice. So it only applies to people, adults who are terminally ill, have a terminal diagnosis with a prognosis of 6 months or less, which is the hospice verification eligibility standard. They also have to have full decision-making capacity, the ability to make their own healthcare decisions, give informed consent. So someone with dementia, for example, would not qualify. And then finally, they need to be able to administer, which is ingest the medication themselves through the GI tract. So swallowing or through a feeding tube or a rectal catheter. But there are no injections. This is not euthanasia. It's not what we do to our pets. There's nobody, doing this to someone else. It's really proactively the decision, the choice, and the action taken by the patient. And then the law also requires that two separate physicians, or one may be a nurse practitioner, fully evaluate the patient, be sure that they qualify, that they can give informed consent, that they are not being coerced. And hospice there is also, and many of the patients, most of the patients are enrolled in hospice, which is what we want. That hospice care then adds another layer of support.
Okay. In terms of self-administering, let me just ask you a technical question. I know people who have passed away because of ALS, one of the cruelest diseases out there, and you do lose even the ability to sometimes swallow. Would they still be eligible?
So it really depends. If they can swallow, they certainly don't need to mix their liquid, and all they
Yep.
need to do, be able to do is suck from a straw and swallow. And so there are plenty of people with ALS who do that,
Okay.
who can do that. And there is a window with someone with a neurologic disorder. There are more and more technologies that make more possible, like eye gaze technologies. But you're right, there is a window of opportunity for folks who, if they're going to lose their abilities to their musculature or swallow, they may go too far and miss that window. But that generally is well within a 6 month window of prognosis.
How do you respond to opponents of this, like Senator Utke from Minnesota, the state senator, who says that this lends itself to being manipulated? And he even uses the concerns about economics. In other words, a family has a loved one who is dying, has a terminal illness, and needs to be in a nursing home. And we all know how astronomical that expense is and the drain that it places on the family, that would give an incentive for family members to terminate somebody's life. How do you respond to that?
Well, first of all, you have to look at the cost of medical care, which is all in the back, in the rear view mirror. So by the time people have gotten to this stage of death, all the expensive care has been done. So what we're really talking about is hospice reimbursement, which is fairly minimal. So there's not a huge incentive, and that's a Medicare covered benefit. So there's not a huge incentive. There's not a lot of money to be saved. And frankly, individuals can make up their own decisions about whether they want the kind of care that they want. So remember, this has to be somebody who makes up their own mind. They make up their own decision and they are not being coerced. So it's not an opportunity for somebody to come in and force another person. Nobody can make that decision. No other guardian or healthcare proxy can make this decision. It has to be with that person. And then there's the hospice team of people who are there focused on that person's end of life care and desire and wishes. And so it really comes down to that individual person's making that decision free from coercion.
Let me ask you, is our palliative care system right now, our hospice system, which I think in Minnesota is very good in my experience, where they do provide loved ones and caregivers essentially an arsenal of drugs? That's what happened in our cases that I know of, where if you do need it, you can provide this to help the person. And oftentimes that arsenal of drugs is enough to make somebody pass away. Isn't that sort of already in place, and do we need this?
Well, we have excellent hospice care. And you're right, hospice care manages the end of life for the majority of people. But in some instances, and we're not just necessarily talking about pain, but there may be other symptoms resulting from cancers that bulge out of the eye socket, eat through the skin of somebody's neck, cause fistulas, cause fluid to build up in the abdomen that then creates pressure on their breathing. So there are lots of symptoms that aren't necessarily pain, seizures, hallucinations that come with brain cancers. So that often cannot be treated. The kind of pain that comes with bone cancer or the headaches that go with brain cancer, those can't be treated. So, but what hospice can do is put them into a coma. So they can induce a coma. And that's the option that they have at this point is we will put you into medical coma and then, you will slowly deteriorate and die if you choose to stop having any nutrition. So, yes,
That's
they
already
can
in
do
place.
that. Pardon me?
Isn't that already in place right now?
That is already in place. And
Okay.
so what some people are saying is, I don't want to go through that.
Okay.
I would rather have this option, take this medication now, say goodbye to my loved ones, fall asleep, die gently in my sleep. I don't want to be put into a coma where I linger for 2 weeks while my family watches me deteriorate. That's, and, some people right now can stop eating and drinking at the end of life, which is doable, but not easy. Again, your family's going to watch you go through a dehydration process over a week to 10 days. So in some ways, medical aid in dying it's an alternative to that for people who want to make that decision. And it's not that they can't put you into a comatose state. They can do that. But some people don't want that. They don't want that option.
Well, Dr. Rebecca Thoman, thank you so much. You've really done a great job of explaining sort of the nuances here, and it'll be interesting to see if this finally passes.
Thank you so much for taking the time to interview me.
Joining us right now is Senator Paul Utke of Park Rapids, and he is the former chair of the HHS committee and is currently the minority lead on Health and Human Services. Thank you so much for coming on.
Thank you for having me.
You've really been emphatic about this bill, your concerns about this bill, this so-called right to die bill. Tell us about those concerns.
Well, the concerns are many in the fact that, starts out with it's basically physician-assisted suicide, and we have concerns with that people would possibly want to take their life for a lot of different reasons. And of course, this is when they've been diagnosed with a life-ending major disease or a healthcare issue, so that they would be basically told that they've got 6 months or less to live. So it is in their last months of life, but I fully believe that, this should not take place. Every life is a gift from God, and we want to do everything we can to extend that life. And if it gets to the point where it's just not, our medical facilities and such are not capable of extending their life, we do have cares in place already, whether it's comfort care, pain care, hospice care, to help these people in those last days. So I think we've got a good system in place. And so that's why I have a lot of concerns with what's in this current bill.
Yeah, I know that I read that you said this issue should not depend on your quality of life, your mental health, or even your income. I think I understand the first two. What were you referring to when you mentioned concerns about income?
Well, there can be a number of things there. We all know that when we get to that state of time in life where we need this extended care, it's expensive. And people may make this decision to just save some dollars. Maybe they think they can't afford it, or they want to save some of that money and pass it on to heirs, family members. Those type of considerations should not come into play in this. Again, every life is valuable. We should be doing what we can to preserve it and extend it to the best of our abilities, and to, We are all going to, unfortunately, expire at some point. We know that it just happens, but we want that or them to be able to extend that to the very end if they can.
You know, your point about income is so interesting because I think all of us have confronted that and dealt with the incredibly high cost of care for nursing homes and for assisted living even. Are you also concerned that people, not just the individual who is considering the end of his own life, but also the relatives or friends or associates of that person could be making this decision out of for a monetary reason?
Yes, I am definitely concerned about that. For the upfront current costs, this bill also goes in and talks about their insurance policies and such. If you could move up those payouts because of, a terminally ill patient. We just don't want any of these decisions being made based on financial conditions. It has to be everything circled around and centered on the health of that individual.
You're also, it's interesting what you're talking about in terms of you feel the systems are in place right now to handle these situations. And it is true in my own experience, dealing with people who are in palliative care or hospice, they have, in my experience, given the caregivers medications to ease pain, to make things easier. And in the end, these medications, which can be very powerful, are ones that certainly move along the process of ending a life. You're satisfied with what we've got now in palliative care and hospice care?
Yes, I am. There we have care being administered by a provider, and they're whether it's your pain level or whatever the issue might be, they're there to make you comfortable. In this case, you would see your providers, and it goes through the various steps that you need to accomplish to be able to qualify for your prescription. But you end up getting a prescription for life-ending medications, and then this person would self-administer. So now they're taking that medication to end their life purposely, where the other side, it's a little different. I mean, if somebody's suffering from severe pain and it's in their last days, yes, they get pain meds, they get comfort, whatever needs to be administered to keep them comfortable. But this is kind of different because they're self-administering. They know that at that point, if they consume it, it's end of life.
Senator, let me just ask you quickly, do you think this is the year this could pass? I mean, this has been kind of proposed for a number of sessions and really not gotten anywhere.
We hope it doesn't pass, and I don't know that it will. This is a pretty serious issue. It needs more time. It needs more conversation. I think people need to fully understand what's being proposed. And, if it's ever to be something that's considered, I think it needs a lot more input because there's a lot in this bill, and I don't think people fully understand it, and it's got some serious consequences.
All right. Well, Senator Utke, thank you so much for your time. We really appreciate it.
You're welcome. Thank you.
And that does it for this edition of Talking Points. Please email me at esme@wcco.com with any comments or suggestions. The show streams every Wednesday and Thursday night at 6:30 and 9:30 p.m. On Friday, the show posts to YouTube for on-demand viewing. Thank you so much for watching. I'm Esme Murphy, WCCO News.